All right, great topic again, a continuation from last week. It is Polymyalgia Rheumatica.
Yeah, should we do our...
Yeah, we should. Oh, wrong way. Okay, learning objectives. Be able to differentiate polymyalgia from other rheumatic diseases. I think that's one of the major things. Understand best tests for diagnosis and know how to treat successfully.
Can I ask you to give the case?
Yeah.
Okay.
So tying back to our talk about giant cell arteritis, there was a patient that was diagnosed with giant cell arteritis. She had a positive temporal artery biopsy. After some visual changes, she was treated with high-dose steroids. And then in follow-up, when she came back to her primary care physician, they were able to put two and two together because approximately 1 year ago, she started having bilateral shoulder pain. She was initially sent for x-rays and physical therapy because they didn't see anything on x-ray. After she didn't respond to physical therapy, they actually gave her bilateral steroid injections, and she did quite well with those.
Yeah, exactly.
And she says, you know, the physician actually told her, well, you know what? You had polymyalgia rheumatica then, and then you progressed to giant cell arteritis.
Yeah.
So that's kind of just a cautionary or a learning point from a patient case.
Yeah, and you know, I couldn't help when I started preparing for this topic. A lot of the residents rotate through with me on Friday morning. We do an injection clinic, and we see a lot of shoulder injections, and I always...
Bilateral is the key.
Yeah, and so it's something to think about.
It is.
And I hope it hasn't walked in and seen me and gotten better for a little bit and walked back out, because the shoulder injections is 60 milligrams of prednisone.
It's going to make it better.
Yeah, and if you do bilateral, it's 120.
Mm-hmm.
So it's
and it's a shorter-lived disease, so by the time that steroid wears off, you might have actually resolved your PMR. So just another differential diagnosis to really kind of keep your awareness up.
But what I liked about the case is it highlights that there's a huge overlap, and you don't want to get locked into your thinking of, oh, this is just PMR again.
Yeah.
Because there's a big overlap with giant cell arteritis, and the visual loss is real, and so...
And the stroke and the arteritis, and
Yes.
the aortic dissection and stuff, so...
I'm going to butcher this quote, but I think the quote is something along... It was a diplomat. It says, when the facts change, so do my opinions.
Yeah.
So you have to pay attention to what's going on with the patient.
That's a timely quote, but
It
we
is.
won't go into
Yeah. So the diagnosis of PMR...
Well,
Send the lab.
can we go back a
Oh, I'm
little
sorry.
bit on the
Yeah.
handout? So again, kind of back, PMR and giant cell arteritis, they're not sure, but they think it's kind of they share genetic susceptibility. But the difference is PMR is actually a true synovitis of the proximal joints.
Yes.
And whereas
mostly
other rheumatic
shoulder.
diseases are distal.
Mm-hmm.
So, and shoulders more often.
Yeah, I think one of the vignettes was if they have synovitis in hands and
Yeah.
things, you really think about something else.
Yep. It's interesting that in polymyalgia rheumatica, you can get some swelling like on the dorsum of your hands and feet, but that's a tenosynovitis, and not like the joints with rheumatic, you know, rheumatoid arthritis and stuff. So kind of, you just really got to be really aware. And then the symptoms, again, I think we should go over that.
Yeah.
You know, inflammatory symptoms, weight loss is common. Both giant cell arteritis and polymyalgia rheumatica can present in an older person as a fever of unknown origin, so remember that. And then the cases that I've seen, people don't necessarily complain of pain. They complain of, I can't get out of bed in the morning. And a lot of that's related to some hip stiffness. They won't even call it pain or shoulder. So, you know, stiffness, again, kind of that inflammatory pattern of at least an hour of symptoms, but that's literally what they complain about.
Yeah, I was thinking back to the last case I had was a 68-year-old man, and his was stiffness, and he noticed that he had to help himself up.
Right, so it almost seems like a dysfunction rather than rheumatic disease when patients complain of it. Patients don't read the books.
Yeah.
They can only tell you what they're experiencing, and that's my experience of what they're going to tell you.
And when this guy came to me and said, well, I'm stiff all the time, and he was doing this,
Yeah.
showing me how he was, I started thinking about myositis.
Right.
You know, because it sounds like, well, geez, this large muscles, and then he went on and it was his shoulders, and...
If you think about PMR is like from here to here, right? I mean, that's what it is. It's not, you know, so that can help give you a clue. So... But now on the diagnosis. Sorry,
Yeah, so, no, go ahead. How do we make the diagnosis? Any takers?
Clinically.
Good.
Good answer.
Good. So good history
That is
and
the most
physical.
important.
Yeah, and is there any labs or anything you want to do?
ESR.
ESR.
Yeah.
Yeah.
What I thought was interesting in reading up on this is 90% have an elevated SED rate, but the cutoff that they use in the research trials is a SED rate from 30 to 40. And this is mostly a disease of people at least over 50, mostly around 70. So I don't know if I would necessarily bat an eye at a SED rate of 30 and a 70. Right?
That's actually more of a normal SED rate for an elderly person. There's a calculation where you put in the age and the gender for what your SED rate should be, and it should be around 25 to 30.
Yeah.
I think the point of that is that there's actually, they're finding that there's a lot of polymyalgia rheumatica out there without an elevated, what we would consider an elevated sedimentation rate. So back to your point of it's a clinical diagnosis, and if they respond to prednisone, you got it.
Yes, it's what I call practicing medicine.
Oh, I like that.
And
We
I
like
think,
to do that.
Yeah. One thing I learned too is ultrasound can be helpful. They
Yeah.
can see inflammation.
So that synovitis is there.
The synovitis is there in the shoulders. And then I guess if you're basically making the diagnosis by practicing medicine or you're going to do empiric therapy, what I like to do is kind of what I call dotting the I's and crossing the T's. And that is running through your differential diagnosis and saying what else could it be and does this reasonably fit? And is this the best fit?
Yep.
So what other things would you guys think about? Rule number one is if in doubt, it's a drug or a virus, Dr. Fowler. Looking at the handout, that's good.
Busted.
So drugs or viruses that cause myalgias or muscle aches. Oh, you guys got to have at least one.
Influenza.
Good! Dr. Baumgartner with influenza.
Yeah.
I'll take statins.
Yeah.
OA. Osteoarthritis.
Sure. It can be very confusing because again, they're not like saying my joints are swollen or anything like that. That's how that lady presented and got shoulder injections for what was presumed to be OA.
HIV. Some of the nucleoside reverse transcriptase inhibitors can cause myalgias. Alcohol, cocaine, anti-malarials.
Hopefully not too many 80-year-olds using cocaine out there, but I've learned never to say never.
Dr. Norris told me he had a 70-year-old using PCP.
It's amazing they get to that
And I
age.
have a 75-year-old that's using cocaine.
Yeah. Antipsychotics are a big one, I think.
Yeah.
Antipsychotics is one of my drugs that I will, if somebody's on an antipsychotic and somebody has a symptom, I worry about it being related to antipsychotics. Diabetes, sexual dysfunction, high prolactin.
The weight gain.
The weight gain. So that's, not that you necessarily want to stop it, but
Yeah, exactly.
they might go to the cocaine by then. So.
Yeah. TNF alpha inhibitors. And the other one that I didn't know, I had to look up this class of medicine. There's these checkpoint inhibitors for advanced malignancy that they're using. They can either inhibit the inhibitor or the other way around. Essentially what the idea is that they want to activate the immune system. And a huge number of people that are on these show up with basically what looks like PMR that is induced by inhibiting.
It's actually used real commonly in breast cancer after you have chemo. And so those people almost always get joint aches from that. And I can't remember the name of the...
I can't either. There's a bunch, and it's a class of medicines, and I just thought it was important to keep it in my mind.
Right.
You would hope that the oncologist would be very attuned to this, and they're usually pretty good about running through things, but it's something, if they come into the hospital or something, you want to really be aware of it.
Yeah.
I think in the elderly, too, one thing I put in there is depression. Fibromyalgia, somatic pain.
Yeah, it's all common.
Yeah.
And I think, again, looking at your most risk group, again, female more than male. An interesting article I read is like in people of Northern European descent and people in Minnesota. I laughed when I read that in there because, there's supposed to be more Scandinavians, I guess, in Minnesota. But frankly, my husband's from South Dakota and they're all Swedes and Norwegians up there too. So just think of Northern European, Northern United States. That's how I like to look at it. And then we all mix up so much anymore, it doesn't necessarily matter.
Exactly.
But treatment, there's a big difference between polymyalgia rheumatica and
giant cell.
Giant cell. What's the difference? It's still steroids.
Duration.
What's that?
Duration.
Duration is big.
Duration and dose. So a fraction of the dose, usually about 15 is what I do of prednisone.
I use 20.
Yeah.
But your taper can be quicker. But they do seem to relapse. You might get better, and then a year from now, they might get it again.
Yeah.
Or it might be giant cell arteritis, going back to the initial point.
Yeah. So always keep your eyes and ears open, because if the facts change, you should change your thinking.
Right. And you can use methotrexate in PMR as well for steroid sparing. Some people just can never get below that magic 25 to 20. And those are the people, again, you want to use methotrexate in. So,
Yep.
yeah. Good
Should we
topic.
key points?
Yeah. Key points. PMR is a disease of the synovium, including tenosynovitis, versus a disease of the vessels, as in giant cell. PMR and giant cell arteritis are separate syndromes but can overlap in the same patient. Symptoms are proximal joint stiffness first thing in the morning for more than 1 hour, along with other inflammatory symptoms. And treatment is steroids, but a lower dosage than in giant cell and often shorter time period. A sweet topic.